Coming up in this episode. So, if your clinical question is, I've got a patient with a Parkinson's plus syndrome, but I'm just not sure which of the three it is, a DAT scan will not be able to answer that question for you. But if your clinical question is, I've got a patient who's been on haloperidol for 20 years, but they've got Parkinsonism with asymmetry, and I think this might actually be primary Parkinson's disease rather than drug-induced Parkinsonism, but I'm not sure. Or if your clinical question is, I've got a patient who's had strokes in the past and they've got terrible white matter disease in their basal ganglia, but they're really Parkinsonian and they do have asymmetric findings. It's very unilateral. They do look like a classic Parkinson's disease, perhaps, and I'm not sure which of the two it is. That's arguably where a DAT scan might actually have the best use case. That's where it may be the most useful clinically, although this study didn't specifically look at that. So it would be helpful to have studies looking at that and confirming that with neuropathological findings, and that's what the authors point out. Hello, and welcome to the next episode of Risfeld Neurology Education, a not-for-profit, free open access project with a philosophical touch exploring all areas of clinical neurology, meant for medical students through to neurologists and any health professionals caring for patients with neurological conditions. I'm your host, Tom Risfeld, a neurologist, epileptologist, and neurophysiologist and neuromuscular specialist, and also a physician, philosopher, and bioethicist. I'm excited to announce a new episode today titled Dopamine Uptake Scan, also known as DAT SPECT or DaTscan, Diagnostic Accuracy for Parkinson's disease / primary extrapyramidal syndromes Journal Club. And this falls within both the Parkinson's disease and movement disorders series and also the Journal Club series. And I'm recording this episode on a weekend, so I'm in a casual Sunday t-shirt and I'm wearing one of my favorite Renee Magritte t-shirts. So that's why I look a bit different today. This episode, of course, is a Journal Club episode, so it's going to be a bit more advanced. So it's probably more suited towards some of the subspecialty neurology trainees and neurologists specifically. But I do anticipate that more junior audience members will also find this useful, both clinically and also as an exercise in how to evaluate a clinical study to draw conclusions for it and implement those into your clinical practice if appropriate to do so. And before we proceed, a legal disclaimer: the content of this episode is for educational purposes only. And also, any post-publication corrections which I may happen to come across will be included in the video and audio podcast descriptions. So without further ado, the paper that we're going to be looking at today was published last year in Neurology, or the Green Journal as they call it, and it's titled Neuropathologic Validation and Diagnostic Accuracy of Presynaptic Dopaminergic Imaging in the Diagnosis of Parkinsonism, authored by Hastings and colleagues. So I've just included a screenshot of the abstract for those who are watching along on video, but I'm going to skip over this because we'll be talking about the study in detail for the rest of this episode. So a bit of background first to set the scene. So what are the primary extrapyramidal disorders? Well, they're Parkinson's disease, of course, PD, or some may say idiopathic Parkinson's disease. Then there's multiple system atrophy, MSA, progressive supranuclear palsy, PSP, and corticobasal degeneration, CBD, or some may say corticobasal syndrome, CBS. And some may draw a slight distinction between those two, but we're going to use those interchangeably. In terms of the clinical diagnosis, it can be challenging because there is significant overlap between the clinical features of some of these conditions, especially in the early stages. And the clinical diagnosis has an accuracy of about 70 to 80% in clinicopathological series, so series that have looked at the clinical diagnosis and then compared that with the pathological diagnosis. Of course, there are other types of conditions which can also present with extrapyramidal features. So you can have other neurodegenerative conditions that can have overlap with extrapyramidal features. For instance, some of the dementias, so not Parkinson's disease with dementia, but say Alzheimer's disease with extrapyramidal features, or frontotemporal dementia with extrapyramidal features, or olivary degeneration syndromes. And then there can be non-degenerative pathologies that can also present with extrapyramidal features. So you can have tremor predominant syndromes such as an essential tremor or a dystonic tremor. And you can have drug-induced Parkinsonism, especially in a mental health patient who's been on high dose or long-term antipsychotic medications, so dopamine antagonists, and also vascular Parkinsonism. And that's often a differential diagnosis for Parkinson's disease, especially if there's lots of chronic small vessel microvascular ischemia seen on the imaging in the basal ganglia. And of course, it can be difficult when there's overlap between a question of is there degenerative pathology? Yes, we know there's some ischemic changes radiologically and perhaps a clinical history of ischemia as well. And it can be hard to tease out sometimes. And this is important because, say, Parkinson's disease responds much better to levodopa therapies, dopaminergic therapies, whereas a lot of these other conditions, and especially some of the non-neurodegenerative conditions, such as, say, vascular Parkinsonism, are not expected to respond so well to dopaminergic therapies. So, why is an early and accurate diagnosis important? Well, it's important for prognostication, for counseling and care, and it's also important for early treatment and for enrollment into clinical trials, although this is acknowledging that there are no disease-modifying treatments which currently exist for any of these conditions. So we don't actually have a disease-modifying, let alone a cure for, say, Parkinson's disease or one of the Parkinson's plus syndromes, these other primary extrapyramidal syndromes like MSA or PSP or CBD. However, hopefully we will have some disease-modifying therapies or fingers crossed, even a cure in the future. So it is important to diagnose these accurately and early on. But even in lieu of having a cure, it still is important in terms of optimizing the management of the patient and counseling the patient accordingly. So just a quick refresher before we go on as to the clinical and also the pathological features which distinguish Parkinson's disease from those three other primary extrapyramidal syndromes or Parkinson's plus syndromes that I referred to previously. So we know that Parkinson's disease has bradykinesia and then at least one of resting tremor, rigidity, or postural instability. So that's the core clinical features of Parkinson's disease. And then with the plus syndromes, these are the key features, and this is how I would recommend remembering them. So PSP, progressive supranuclear palsy, just remember that the supranuclear, so the S in the middle of the acronym, refers to the gaze centers, which are supra, so above, more upstream to the nuclei, which are actually the cranial nerve nuclei that control vertical gaze. So we're talking about the supranuclear higher order control of gaze centers. And so in PSP, you get a problem with that. So you get a vertical gaze palsy. And it's especially down gaze. So it's not uncommon in more elderly patients to have at least partially restricted up gaze, and that's not necessarily even abnormal or pathological. But if you have a restricted down gaze, then that's much more suspicious of pathology and specifically an extrapyramidal syndrome, which is restricting down gaze. And the reason that it's supranuclear, or the way that you can overcome that, is to do passive neck extension and flexion to move the head up and down, and to see whether the downwards gaze palsy is overcome with passive head movements. So to test down gaze in particular, what you would do is extend the neck and ask the patient to keep looking at your nose, for example, and they weren't able to look down actively. But if you ask them to look at your nose and then you extend their neck, if they're able to continue looking at your nose, then they will have been able to move their eyes down. So that would be a supranuclear palsy. They're not able to volitionally, consciously achieve down gaze because of pathology in the supranuclear pathways, but the downstream pathways are still intact, and the unconscious oculocephalic head reflex, although not the typical horizontal one that we think about when we're thinking about vestibular conditions, the vertical one is still intact. The other things to remember about PSP are falls, and in particular, early and prominent falls. So that's important. So, of course, a patient with Parkinson's disease can fall, but a patient with PSP typically has early prominent falling. And then there are also cognitive and psychiatric features which are common in PSP. And PSP has a number of subtypes as well, which we'll get to later on. Moving on to MSA, multiple system atrophy, what I'd remember, or recommend remembering rather, is the A. in MSA and try and remember the 3 A's. So firstly, remember autonomic instability, as in blood pressure instability, postural hypotension, with associated falls again. So if someone has really prominent orthostatic hypotension early on in the condition, which is often associated with falls, then that may hint at MSA. Of course, you can get that in Parkinson's disease as well, but if it's disproportionately prominent early on especially, then that's suggestive of MSA. Then also think of the second A, which is other autonomic features, such as urinary incontinence or retention, anhidrosis, sicker symptoms, so dry eyes, dry mouth, the sorts of things that you get in Sjogren's syndrome. And then the third A is for ataxia. So if someone's ataxic, then that's suggestive of MSA. Finally, in terms of the third one, so CBD, corticobasal degeneration, think of the 2 C's. So C for cortical, so that's cortical deficits, so things like apraxia, dysphasia, the list goes on. And then the second C, just remember again, cognitive and psychiatric problems. So of course, there's overlap here as well, and there's overlap between each of these 3 additional Parkinsonian plus syndromes as well, but hopefully that paints the picture for you. Then in terms of the proteins involved at a neuropathological level, remember that alpha-synuclein is in Parkinson's disease, and it's also in dementia with Lewy bodies. And remember that Parkinson's disease and dementia with Lewy bodies really are very, very closely related conditions. Some may even argue that they're on the same spectrum. And of course, they both have Lewy bodies. And in Parkinson's disease, the movement manifestations come on first, whereas in dementia with Lewy bodies, the dementia cognitive component comes on first before the movement component. So just remember that Parkinson's, and by extension, dementia with Lewy bodies, are your typical alpha-synucleinopathies. And then also remember that MSA is another alpha-synucleinopathy, and just remember A for alpha and A for MSA. Then tau. So tau accounts for PSP and CBD. So that's the other 2 on the list that hasn't been accounted for yet. So tau is the other 2, PSP and CBD. And it's also in the tau variant of frontotemporal dementia, which is written as FTD-tau. And then I think about it in the reverse in terms of Alzheimer's disease. So in Alzheimer's disease, you get multiple proteins. So you get amyloid beta, of course, in the plaques, the amyloid plaques. And of course, there's the anti-amyloid therapies, which have hit the market recently and are on ongoing clinical trials. We'll have another episode on risk-based neurology education on anti-amyloid therapies in Alzheimer's disease later on. In Alzheimer's, you also have tau in neurofibrillary tangles, and you also have alpha-synuclein as well. So just to reiterate this, because it does come up a bit, so your classic alpha-synucleinopathies are Parkinson's disease and by extension dementia with Lewy bodies, and also MSA, and just remember that A in MSA. Then your tauopathies are the 2 that are left over, so PSP and CBD, and also the tau variant of FTD. And then Alzheimer's disease is a bit of a mixed bag. So you've got amyloid beta in the plaques, tau in the neurofibrillary tangles, and alpha-synuclein as well. More on the background, it's important to recognize that these primary extrapyramidal syndromes, so Parkinson's, PSP, MSA, and CBD, all share some pathologic mechanisms. So they're all biologically characterized by nigral cell loss. So that's the nigral cells in the substantia nigra, the dopaminergic cells are lost. So you get dopaminergic deficits in the striatum and reduction, therefore, in striatal dopamine transporter levels. And the acronym for dopamine transporter, a little bit confusingly, is DAT, so DAT. And that is a presynaptic protein which is essential for the reuptake of dopamine from the synaptic cleft. So what we can actually do is we can radiologically measure the reduction in this presynaptic dopamine transporter protein, the DAT, by using a DAT SPECT, a single photon emission CT, using a specific radiotracer ligand. So of course it's a SPECT scan, it's a nuclear medicine scan. And currently, it's the only diagnostic imaging tool which is available for distinguishing primary extrapyramidal disorders And in this paper, they call them the presynaptic dopaminergic deficits from other conditions with Parkinsonian features, and they describe them as being postsynaptic dopaminergic defects. And I should say the only diagnostic imaging tool which is approved for this use in the United States and in Europe is not really widely available in Australia. Actually, there's been a few times when I thought it would have been clinically useful to get a DAT scan, a dopamine uptake scan on a patient, but it hasn't really been available in Australia. Hopefully it will be in the coming years, but it is available, I understand, in the United States and in Europe. So the reason that the authors have written this paper is they recognize that despite the widespread clinical use of dopamine uptake scans, of DAT SPECT scans in some parts of the world, a DAT SPECT has never been validated against the gold standard of post-mortem pathological assessment, and it has instead been validated against a refined clinical diagnosis. So basically, a patient has a clinical diagnosis initially of condition X, and then they have the DAT SPECT scan, and then that may change the diagnosis, and then that's then used as the benchmark upon which the diagnostic accuracy of the scan is measured against. But of course, this is problematically circular because you don't really have a proper gold standard that you're comparing the diagnostic accuracy of the scan against. So we don't really know if the DAT scan actually works or not based on the previous literature. And the reason it's circular is that the indication for the scan in the first place was because there was clinical uncertainty. So how can you use the clinical outcome as your benchmark? And this is also problematic because DAT SPECT scans have been used as biomarkers of disease progression in clinical trials, despite no clearly demonstrated correlation yet between DAT SPECTs and nigral cell loss. So the current study that we're looking at aims to rectify this research gap and evaluate the diagnostic accuracy of DAT SPECT against the gold standard of post-mortem pathological assessment. Let's move on to the methods. So how did they actually do it? Well, it was a retrospective cohort study. So this isn't a prospective multicenter RCT. It is a retrospective cohort study. So it's an observational study. And they consecutively looked at patients who had had a DAT SPECT scan and also had brain donation for a brain-only autopsy between 2010 and 2021, and they were identified from the archives of the Queen Square Brain Bank and the Parkinson's UK Brain Bank in London, United Kingdom. And the DAT SPECT scan was performed as part of the clinical workup for Parkinsonism, defined as tremor, rigidity, bradykinesia, and or some specific gait abnormalities in any combination. But it excluded patients with a DAT SPECT which was ordered for another indication, namely the evaluation of dementia or cerebellar ataxia syndromes without Parkinsonism. And importantly, some patients with MSA with a pure cerebellar subtype of MSA may lack Parkinsonian features, so those patients were excluded from this study. Clinically, all of the patients had been reviewed by neurologists, geriatricians, and general practitioners, and the medical records were then retrospectively reviewed by a movement disorder subspecialist neurologist involved in the study, or a number of subspecialist neurologists in movement disorders involved in the study. In terms of the PSP subtypes that I alluded to earlier, they were divided into 3 clinical subtypes or phenotypes. The classical PSP, and that's also known as the PSP-RS or the Richardson syndrome, so that's the eponym there historically used. The second type was subcortical PSP, and that included both the PSP Parkinsonism and the PSP progressive gait freezing variants. And then cortical PSP, and that included the PSP corticobasal syndrome, the PSP frontal, and the PSP with speech disorders phenotypes. The pathological assessment component was performed by neuropathologists, including immunohistochemical staining for alpha-synuclein, amyloid beta, phospho-tau, and in some cases other tau subtypes, along with TDP43, which is an important neurodegenerative protein as well, and also fused in sarcoma protein and P62. How does the DAT SPECT actually work? So the proprietary name for the study is a DaTscan, or as one word. with an uppercase D and T and everything else lowercase. And it's proprietary because they use this radioligand called 123-I-ioflupane. And it was injected 3 to 6 hours prior to the imaging, and any drugs potentially interacting with the striatal tracer uptake were discontinued prior, although further details regarding this were not provided. And then the images were interpreted by a nuclear medicine specialist, or specialists rather, although they were not blinded to the clinical information. So a potential shortcoming there. Abnormality was defined by any of the following. Firstly, asymmetric uptake in the putamina. So that means that one of the putamins had normal activity, and then there was reduced activity in the other putamen. And the side with the reduced activity had to be contralateral to the side where the clinical deficits were. Secondly, there could be significant bilateral putaminal reduction in uptake. Or thirdly, there could be global bilateral reduction in uptake in both the putamini and in the caudate nuclei, compared with nonspecific background uptake in the rest of the cortex. Now, for those who are watching along in video, I've included an image which was actually taken from another paper by Kupsch et al. In 2012, published in Neurodegenerative Diseases, because it was a really nice example of what a normal DAT scan looks like and what an abnormal DAT scan looks like in each of the 3 ways that I described previously. And I'll do my best to describe it for those who are listening on audio-only versions of the podcast. So a normal scan, it lights up really nicely in the caudate nuclei and in the putaminae bilaterally and symmetrically. Whereas in an abnormal scan, it can be abnormal in one of those 3 ways. So in panel B, there's essentially normal uptake in the caudate nuclei, and there's normal uptake in one of the putaminae, but reduced uptake in the other putaminae. Then in panel C, there's reduced uptake, almost absent, in fact, uptake in both putaminae. And then in panel D, there is globally reduced uptake in both putaminae and also in both caudate nuclei. So I hope that makes sense. So what statistical methods were used? Well, they did comparison between groups using, if it was categorical data, a Fisher exact test, and if it was continuous variables, then they used ANOVA, so analysis of variance models. The diagnostic parameters of DAT SPECT were then calculated, so they calculated the sensitivity, specificity, and positive and negative predictive values and likelihood ratios. And some of the other parameters or variables that they measured were sex, age, years from motor onset to the time of the DAT SPECT scan, and time from the DAT SPECT scan to the time of autopsy. And that's really important because if the motor symptom onset was very short before the DAT SPECT scan was performed, you might expect that there's been less time for neurodegeneration to occur and less time for more dopamine transporter loss to occur. So you might expect the scan to be less accurate. And the opposite is true as if you have a bigger gap. And then in terms of the time from the SPECT scan to the autopsy, if there's a short gap, then you might expect that the autopsy will accurately reflect what the true state of the dopaminergic system was at the time that the scan was performed. But conversely, if there was a very long gap of years and years and years and years, it may be that there was further disease progression or intercurrent diseases which developed after the scan was performed but before the autopsy was performed, which could also be a confounding variable. So that's why they looked at those factors as well and assessed them for any statistical significance. Secondary exploratory analysis was then performed excluding CBD from the cohort to adhere with the pre-existing literature on the topic. So let's now turn to the results, what you've all been waiting for. So basically 189 patients were included in the study, slightly more males than females, about 58% were male. And on the screen you can see now the resultant neuropathological diagnoses at the end of the study. But I'm going to skip over this because I'll talk to it shortly in some of the following slides. This is their table 1 in terms of the baseline demographic data for each of the groups. I won't go into too much detail on this in the interest of time, but if you're interested, you're free to pause and have a look or look at the study. But some of the factors that they did look at were, as I mentioned before, sex, age at disease onset, age at death, survival from symptom onset, the final clinical diagnosis, the disease characteristics at the time of the DAT scan, so whether the DAT scan was normal or abnormal, the disease duration at the time of the DAT scan, and the interval between the DAT scan being performed and the autopsy being performed. They also looked at the clinical diagnosis at the time of the DAT scan, and they looked at clinical features that were present at the time of the DAT scan. So was there tremor or Parkinsonism other than tremor? Were there other movement disorder features present? Were there cerebellar signs, falls? Was the patient in a wheelchair? Was there cognitive impairment? Or was there specifically dementia present? So this diagram here is probably the most helpful diagram. So there are basically 3 time points. There's the time point of the clinical diagnosis at the time of DAT imaging. Then there's the diagnosis at the time of death, clinically. And then there's the pathological diagnosis at the time of autopsy. Unfortunately, it's a little bit unclear to me reading the paper and looking at this graph whether the clinical diagnosis at the time of the DAT imaging, so the first time point, whether that was the clinical diagnosis before the imaging was performed, immediately beforehand, or whether it was the overall diagnosis immediately after the imaging was performed. So that's a little bit unclear to me. And it's also a little bit unclear as to exactly how the DAT SPECT contributed to the diagnosis at the time of imaging and at the time of death, because of course there's other factors that could have contributed to those diagnoses as well, especially such as clinical progression at the time of death that happened after the initial clinical diagnosis. However, the main statistical analysis that was performed was looking at the third time point anyway. So it was comparing the pathological diagnosis with the DAT findings when the patient was still alive. So this confusion is a bit unfortunate, but it doesn't actually affect the main statistical analysis that were being performed. And this also demonstrates a flow diagram between the clinical diagnosis at the time of death and what happened to those patients and how they were then reclassified or not reclassified when the autopsy was performed, and then what the actual abnormal DAT was in those patients. So the numbers that I'll draw your attention to are, of the 189 patients, the final gold standard pathological diagnosis turned out to be Parkinson's disease in 47 patients, and all of them had an abnormal DAT. So 100% of the patients had an abnormal DAT who ended up having a final diagnosis of Parkinson's disease. Then 73 patients turned out to have progressive supranuclear palsy, 93% of whom had an abnormal DAT. 42 patients had MSA, 98% of whom had an abnormal DAT. 10 patients turned out to have CBD, but only 60% of those had an abnormal DAT. 3 patients had Alzheimer's disease, and a third of those patients had an abnormal DAT. 8 patients had frontotemporal dementia, and only 63% of those had an abnormal DAT. 1 patient had a prion disease, presumably a form of Creutzfeldt-Jakob disease, and that patient did have an abnormal DAT, so 100%, but N of 1. And then 2 patients had a form of restricted neurodegeneration, and half of those had an abnormal DAT. And then 3 patients were found not to have any neurodegenerative pathology at all, and none of those patients had an abnormal DAT. So, what do we actually make of this? Well, firstly, you can do receiver operator characteristic curve analysis, so ROC analysis, ROC, to assess the diagnostic performance of a clinical investigation in medicine. So what that does is it has a y-axis of sensitivity and an x-axis of 1 minus specificity. And basically you want the line to be as close to the top left of the chart as possible and as far away from the bottom right of the chart as possible. And there's a diagonal line from the bottom left to the top right, and that's reflected by what chance would be. So if you just flipped a coin, then they would be the results that you want. So if your test is better than chance, then you want to be above the line. And if your test is so bad that it's even worse than just chance, then it's below the line, basically. That's my understanding of receiver operator characteristic curves. And what this shows is that the ROC curves were quite good for all of the conditions apart from CBD, where it performed quite poorly, relatively speaking. And the actual numerical quantification is based on the AUC, the area under the curve. And for Parkinson's disease, it was 0.77. And it was very similar for all the other categories, including the cohort as a whole, with the exception of CBD, which had a much lower score at 0.57. Now, this table then calculates the sensitivity, specificity, and the positive and negative predictive values and likelihood ratios for each of these conditions. But let's go through it slide by slide. So firstly, how accurate is DAT SPECT in Parkinson's disease? So it had 100% sensitivity. So you'll remember spin out. So spin, specific rules in. So specificity rules in. And then the opposite, sensitivity rules out. So 100% sensitivity in this cohort means that if you think you have a patient with Parkinson's disease and you do a DAT SPECT and it's negative, then that effectively rules out the diagnosis of Parkinson's disease. However, it only has 53% specificity in distinguishing Parkinson's disease from the group of conditions that don't constitute primary extrapyramidal conditions or primary degenerative conditions affecting the basal ganglia and the extrapyramidal system. Now, moving on to the DAT SPECT accuracy in multiple systems atrophy, MSA, it also had excellent sensitivity at 98%, and that worked out at 90% negative predictive value. And importantly, it had 100% sensitivity in the MSA-P phenotype. So the Parkinsonian phenotype of MSA was also 100% sensitive. So a negative scan rules out that condition based on this cohort. But again, it only had a 53% specificity. So in terms of ruling the diagnosis in for distinguishing MSA from the non-Parkinson's or Parkinson's plus syndromes. Now moving on to PSP, it had a sensitivity of 93% and therefore a negative predictive value of 72%. So pretty good, but not as good as for MSA and Parkinson's disease. And there were no statistically significant differences that were identified amongst the different phenotypic subtypes of PSP. And again, the specificity was not so impressive. It was only 53% in distinguishing PSP from any non-primary extrapyramidal disease diagnosis. And finally, the accuracy of DAT SPECT in CBD was not so good. So only 60% sensitivity, and again, only 53% specificity in distinguishing CBD from non-primary extrapyramidal conditions. So what about if you group the whole cohort together? So if you group the 4 diagnoses, so the primary dopaminergic degeneration, the primary extrapyramidal conditions, and you compare that with distinguishing them from something else, so not one of these primary extrapyramidal conditions. Well, it had pretty good sensitivity, 94%, but again, only 53% specificity. Despite this, having an abnormal DAT SPECT had an adjusted odds ratio of 18 for predicting a patient being positive, so having a primary extrapyramidal condition, with a p-value of less than 0.001. So quite impressive results there in that respect. So we'll talk about that more shortly, but firstly, what about the patients who didn't have a primary extrapyramidal condition, who did have an abnormal DAT? Because those patients are the ones that really threw out the specificity measures. So firstly, 17 of the patients who had a neuropathological diagnosis that fell into the PDP negative group, so the non-primary extrapyramidal condition group, 8 of those 17 patients had an abnormal DAT SPECT. But importantly, of those 8 patients who had an abnormal scan, and I'll quote, all cases showed varying degrees of nigral neuronal loss on autopsy, ranging from mild to very severe. providing pathologic support for the abnormal DAT imaging results, apart from one patient with Alzheimer's pathology present clinically with corticobasal syndrome. 2 patients had additional Lewy pathology considered to be secondary findings not responsible for the clinical presentation because of its restricted distribution and severity, although they may explain the abnormal DAT imaging. So basically, in most cases where the patient didn't have a neuropathological diagnosis of a primary extrapyramidal condition, but still had an abnormal DAT scan, almost all of those cases were explained by neuropathological findings of at least some degree of degeneration in the basal ganglia, so in the primary extrapyramidal system. So it's almost as if the scan seemed to be too good at picking up those early changes to explain why the specificity results were not so impressive. So how do we interpret this, and what impact or meaning does it have? Well, firstly, it's important to think about what this means for Parkinson's disease and this concept of SWEDD or SWED. So that stands for scans without evidence of dopaminergic deficits. So this study in their cohort showed that 100% sensitivity and 100% negative predictive value for Parkinson's disease. So what that means is that if a patient was thought to have Parkinson's disease, but then they had a negative scan, absolutely none of those patients actually had then a neuropathological diagnosis of Parkinson's disease. So it strongly counts against the concept of a patient with a clinical diagnosis of Parkinson's disease without having evidence of dopaminergic deficits when nuclear medicine imaging is being performed. So it's basically challenging the theory that that patient cohort even exists. However, this is important because this patient cohort has been thought to exist and has been included in previous clinical trials of Parkinson's disease. So you could argue, based on these studies, that if you have a patient with presumed Parkinson's disease and then they have SWED, so a scan without evidence of dopaminergic deficits, then really it was probably a misdiagnosis and the patient probably doesn't have Parkinson's disease. So you probably shouldn't be enrolling them in a clinical trial regarding the management of Parkinson's disease. Then in the study, there were 2 patients who had clinical diagnoses of Parkinson's disease on the pre-DAT SPECT, which then had a negative DAT SPECT. But both of these patients were later re-diagnosed as PSP clinically. So the initial diagnosis of Parkinson's disease was really challenged by the fact that they had a negative DAT. But then before the time of death, both the cases were re-diagnosed clinically into PSP. And then on autopsy, histopathologically, this was correct for one patient. They did actually have PSP, whereas the other patient had restricted neurodegeneration affecting the inferior olive and globus pallidus. So, what can we draw from this study? Firstly, a negative DAT SPECT seems to exclude Parkinson's disease with a 100% accuracy. A negative DAT SPECT seems to exclude the Parkinsonism subtype of MSA with 100% accuracy, and is quite good at excluding MSA generally, and reasonably good at excluding PSP generally. Furthermore, what I'm about to say may seem at face value a bit paradoxical, but even though there was poor specificity, there was actually good positive predictive value for a patient having a form of primary extrapyramidal condition, so what the authors described as the PDP positive group, and the positive predictive value was actually 95%. And the reason for this, and this is grouping the 4 conditions together under the umbrella term of primary extrapyramidal syndromes or PDP positive. The reason for this relatively low specificity but the high positive predictive value of 95% is because the vast majority of patients in the population did actually have these conditions. So the pre-test probability was already very high. So you start with someone who has a high pre-test probability, then you do a test and the specificity wasn't great, but it was still better than nothing. And so it just increases that number even higher. However, and this is a really important fundamental point to understand, applicable not just to this study, but to clinical studies and diagnostic tests as a whole across all of medicine, is that if the test, in this case the DAT SPECT scan, was administered indiscriminately to a less highly selected population, then the poor specificity of the test would mean that the positive predictive value or the resultant post-test probability would be much lower than what was seen in this cohort. So you've got to remember that these patients were a cohort of patients who had a DAT scan ordered because they had Parkinsonian features but without a clear diagnosis. And that's why the majority of patients did not actually have Parkinson's disease, because if someone has obvious Parkinson's disease, it's not really an unclear diagnosis, so those patients don't really need a DAT scan to begin with. This was a population of patients who had a tricky clinical presentation with Parkinsonian features, but the diagnosis wasn't clear, and they were assessed by neurologists or physicians, geriatricians, and general practitioners. So they were quite a selected cohort with diagnostic uncertainty. And so quite a lot of those patients are going to have these Parkinsonian plus syndromes or perhaps slightly atypical versions of Parkinson's disease proper. However, if you just did DAT scans on everyone or DAT scans on patients who had a bit of tremor but they lacked the cardinal features of Parkinsonism proper, then you're going to have a much poorer positive predictive value and a much poorer post-test probability on the basis of this diagnostic investigation. So that's an important point to be mindful of. So what else did the authors comment? So I'll quote that they did say, one may speculate that DAT imaging may demonstrate better diagnostic performance in the differential diagnosis of patients with PDP plus with other non-degenerative tremoric, such as essential tremor and dystonic tremor, or Parkinsonian, such as drug-induced or vascular Parkinsonism syndromes, although studies with pathologic validation are required to confirm this hypothesis. I would say that this is a really big point, actually, because I would argue that one of the most useful use cases for a DAT scan is distinguishing a patient who you think does have a primary extrapyramidal condition, so Parkinson's, CBD, MSA, or PSP, versus someone who you think doesn't have a degenerative Parkinson's condition at all. So essential tremor or dystonic tremor or drug-induced Parkinsonism or vascular Parkinsonism. So that would be really, really useful to be able to determine. And there was a hint in this study that it may be able to do that because all of the patients who had non-neurodegenerative pathology at autopsy had normal DAT scans. And importantly, the authors don't actually say this in their paper, but a DAT scan cannot actually distinguish between those 4 types of primary extrapyramidal conditions. So if you have a patient with Parkinsonism and they have an abnormal DAT scan, that cannot distinguish between Parkinson's disease, MSA, PSP, or CBD. So if your clinical question is, I've got a patient with a Parkinson's plus syndrome, but I'm just not sure which of the 3 it is, a DAT scan will not be able to answer that question for you. But if your clinical question is, I've got a patient who's been on haloperidol for 20 years, but they've got Parkinsonism with asymmetry, and I think this might actually be primary Parkinson's disease rather than drug-induced Parkinsonism, but I'm not sure. Or if your clinical question is, I've got a patient who's had strokes in the past and they've got terrible white matter disease in their basal ganglia, but they're really Parkinsonian and they do have asymmetric findings. It's very unilateral. They do look like a classic Parkinson's disease, perhaps, and I'm not sure which of the 2 it is. That's arguably where a DAT scan might actually have the best use case. That's where it may be the most useful clinically, although this study didn't specifically look at that. So it would be helpful to have studies looking at that and confirming that with neuropathological findings, and that's what the authors point out. They also point out that there was a significant range in the interval of time between the DAT SPECT being performed and the autopsy being performed, up to 13 years in some cases. And so they identified that it's possible that had the DAT SPECT been performed closer to the time of death, then the sensitivity may have improved. That being said, the sensitivity across the board was really quite impressive anyway. Also, I'll point out that the nuclear medicine specialists were not blinded to the clinical information. They also performed qualitative assessments. However, the authors identified that the quantitative assessment has not been demonstrated to have clear superiority over a dichotomous qualitative visual rating scale in other studies. And in their population, they did do quantitative assessment in some of the patients, so in 14% of the patients, and they found that there were no differences between the results compared with the baseline qualitative yes or no dichotomized visual rating scale that was employed in this study. So my take-home messages for you, and this is my last slide in this presentation, is firstly, although not mentioned by the authors, a DAT SPECT cannot distinguish between Parkinson's disease, progressive supranuclear palsy, multiple system atrophy, or corticobasal degeneration. So it can't distinguish those four conditions from each other. But what it can do is it can rule out some of these conditions, especially Parkinson's disease and MSA with the Parkinsonism subtype. And it is also pretty good at ruling out the cohort as a whole because it has high sensitivity, but not so much for CBD because it only had 60% sensitivity there. However, at least theoretically, this scan is very, very, very useful, hopefully, at distinguishing someone with a primary extrapyramidal condition from a non-neurodegenerative, non-primary condition manifesting with tremor or with Parkinsonian features such as essential tremor or dystonic tremor or drug-induced or vascular Parkinsonism, as I just mentioned, although this study didn't specifically look at that. So further studies in that light would be helpful. And I think we can conclude that ultimately a DAT SPECT can be a useful way to evaluate patients with Parkinsonism, with extrapyramidal features, and an uncertain clinical diagnosis in that it has good negative predictive value, it has reasonable positive predictive value when it's applied to the correct population, and it's likely that it's also very helpful in distinguishing between patients with primary extrapyramidal conditions and secondary non-neurodegenerative extrapyramidal conditions, but that needs to be confirmed with further study. So that's all I had today. So thank you so much for tuning in. I hope you enjoyed it and that you learnt something in regards to Parkinson's disease, primary extrapyramidal syndromes, Parkinson's plus syndromes, nuclear medicine imaging, specifically DAT scans to help tease these apart, and also the difference between a primary extrapyramidal syndrome and a secondary non-neurodegenerative extrapyramidal syndrome, and also learned something about receiver operator curves and ways that we can evaluate the diagnostic performance of a test in clinical medicine. And hopefully you can apply that learning to the rest of your neurology and medical education. So please like, comment, and subscribe if you found this content useful. Visit our website at rneurologyeducation.org for all of our media formats and additional content. Find our video presentations on YouTube and our audio podcasts wherever you listen to your podcasts, and join us on your preferred social media platforms, all at the domain at rneurologyeducation. And email us at contact@rneurologyeducation.org with any questions or to subscribe for updates when new content is released. From cortex to curiosity, this has been Risfeld Neurology Education. Until next time, keep calm and synapse on.